So I've got the tough task to talk to you about gluten and the brain. I've got a lot of things to say to you. I think most of you will be familiar with the concept of gluten-related disorders, which is a nomenclature that we've decided to use in 2011 after a meeting in London to be the umbrella term to describe the group of diseases that are triggered by the ingestion of gluten. And of course, it includes celiac disease, dermatitis herpetiformis, gluten allergy, which is a different immunological pathway, gluten-related neurological manifestations, and the so-called non-celiac gluten sensitivity. So in terms of the neurology, up until 1996, there were a lot of case reports of patients with established celiac disease who then went on to develop neurological problems. What we did in 94, we approached it from a neurological perspective. So we thought, okay, let's screen some patients with neurological problems that we didn't have a cause for, and just let's see whether or not there is a high prevalence of gluten sensitivity. I remember at the time, anti-gluten antibodies was what we had available to screen. And what we found was that the frequency of these antibodies amongst these patients with neurological dysfunction was very high by comparison to the healthy blood donors and those patients where we had a well-defined neurological diagnosis. When we did biopsies, we showed that the prevalence of celiac disease in that group was, again, very high at 16%. And really that led to our interest into the neurological manifestations and the setup of a gluten neurology clinic, which has been running ever since. And I see a lot of patients from mainly the UK, but also sometimes from abroad. So the database now has 853 patients that have been assessed on a regular basis. And you see that the commonest manifestations are ataxia, peripheral neuropathy, encephalopathy, and myoclonic ataxia. And I will talk a bit more about these four commonest manifestations. There are some less common manifestations, which include things like myelopathy, epilepsy, particularly with occipital calcifications, and chorea. What I want you to notice here is that this is the prevalence of celiac disease amongst these groups. And you see that there's differences here. So for example, the myoclonic ataxia are much more likely to have enteropathy than, say, the group with peripheral neuropathy, which is in itself is quite interesting. So if we start with gluten ataxia, so the definition is of a sporadic idiopathic ataxia with serological markers of sensitivity to gluten. And there are now epidemiological studies from all over the world, as far as Japan and China, showing that the patients with idiopathic sporadic ataxia have a higher prevalence of anti-gluten antibodies than other groups. And this is our data from Sheffield. I also run one of the national ataxia clinics in Sheffield, so I've got more than 1,500 patients with different types of ataxia. So gluten ataxia accounts for 20% of all ataxias, 50% of all the sporadic idiopathic ataxias, and you see that that prevalence is much higher than in the control population. Now you may say, well, because of our interest, we have a referral bias, but in fact, when I looked at the database, it's of note that only 13% of the gluten ataxia patients were referred with an existing diagnosis of gluten ataxia. In other words, the majority were diagnosed in Sheffield. These are the clinical characteristics on those patients. 74% have mild ataxia, meaning that they can walk unaided. Moderate in 18%, meaning that they need a stick. And 8% are wheelchair-bound. Slightly female preponderance here. Age at onset is 52, and that's quite important. All of them had gait ataxia. Some of them have atrophy of the balance center on the scan. All of them have abnormal spectroscopy, and 47% have enteropathy when you do biopsies. So what serological markers should we use in the diagnosis of gluten ataxia? Well, EMA and TG2 antibodies, of course, are specific for the presence of enteropathy. So if you use just those, which is what most UK labs use, then you will miss 53% of patients who who potentially have a treatable ataxia. And so we still think that at the moment, IgG and IgA anti-Gluten antibodies should still be used for the diagnosis of the neurological spectrum. So we did a study published in 2003 where we showed that patients who go on to a strict gluten-free diet can show improvement on clinical measures within a year of the diet. And you need to act early, because if you don't, this is what you end up with. So this is the normal looking brain with a normal size cerebellum. And this is the same patient 2 years down the line. By this stage is wheelchair bound, and you can see the atrophy here. And it's at this stage that the diagnosis of gluten ataxia was made. A bit too late in terms of disability. So in 2008, we thought we wanted to use a technique known as MR spectroscopy that allows you to show changes within an area of the brain that you are interested in terms of the demonstrating improvement, if you like, with the intervention. So this is spectroscopy. So the big peak is N-acetyl aspartate. It reflects metabolic activity within the area you are interested in. So if you have an unhealthy cell, this goes down. Creatine doesn't change between health and disease. So the ratio of NA to creatine is a useful marker of health and disease. So this is what it looks in real life. So this is a patient with gluten ataxia. And the first peak that should have been taller than this one, you can see it's quite low. And the ratio here is 0.66, so it's abnormal. In the voxel, you can see the little square over the cerebellum. And here's an example of a patient who started with, diagnosed with gluten ataxia at this stage, baseline 0.56, 18 months on gluten-free diet, increased to 0.79, 30 months on the diet, 0.98. So it's continued to improve over this period of time. And we now have a lot of data because our patients have a scan usually at a year interval after they've gone on to the diet. And this is a group of patients who are strict gluten-free diet, and the serology is negative, proving that they are strict. And you see that the NAA to creatine ratio goes up. By contrast, this is a group of patients that don't want to go on the gluten-free diet for whatever reason. And you can see that in all of them, the spectroscopy goes down, and this is of course accompanied by clinical deterioration. And then in between you have a group of patients who are half-hearted on a gluten-free diet with persistently positive serology, and they're somewhere in between. In general, I think the pattern is that of a slow deterioration. I mentioned myoclonic ataxia, and it's an interesting entity because it reflects the fact that there is what we call a tendency for a CNS hyperexcitability. So why is this important? Because this condition is very strongly associated with refractory celiac disease. So fortunately, it's rare, but when we see it, we worry. And out of this cohort of patients, there are 3 with enteropathy-associated lymphoma, 2 of which unfortunately died despite immunosuppression. So they need more than just a gluten-free diet. When you do clever neurophysiology on them, you can demonstrate that preceding every twitch that you see, there is a spike in the contralateral cortex. So it's a form of, if you like, a focal motor epilepsy. And our colleagues in Catania were able to demonstrate that the evidence of excitability of the motor cortex in patients diagnosed with celiac disease, even if they didn't have any neurological problems at the time of being tested. I hope you had a chance to read the neuropathy poster that Dr. Ziz has presented. He's done some very good work in the last 2 years looking at the cohort of our patients with gluten neuropathy. It accounts for 26% of all neuropathies. And a study from Finland showed that if you do neurophysiological tests, 21% of these patients on supposedly gluten-free diet have peripheral neuropathy. And the work from the population-based studies in Sweden also confirmed that there is this strong association of, if you have celiac disease, you have a much higher chance of having a neuropathy. We did a study where we were able to demonstrate that there is dietary improvement of the neuropathy with gluten-free diet, because the peripheral nerves have the potential for regenerating, unlike the central nervous system. And then gluten encephalopathy is a terminology we use for patients who complain of severe, often intractable headaches, can be a bit like migraine, and they often have white matter abnormalities on the brain scan. The vital thing is that the headache disappears when they go on a gluten-free diet, the MRI changes, stop progressing, but they don't resolve. If they don't go on the diet, those changes might get worse. And again, the work from Sweden confirmed that there was an increased risk of headaches in patients with celiac disease, and that was also true for patients with normal mucosa and positive serology. So these are the kind of changes that you see. So these are these patches of white abnormalities, sometimes referred to as vascular or non-specific. They can be a bit more spotty, like you see here, or they can be more confluent, like here. This is all abnormal. And here. This is a patient who had these spots, but was not keen at all to go on the diet, and this is a change over a 2-year period. You see that's become much more prominent and more confluent. And this is interesting because these are the kind of changes that you might see in the brain of somebody that's been labeled as having vascular dementia. And again, our colleagues in Sweden, when they looked at the risk of dementia in patients with celiac disease, they concluded that patients with celiac disease are not at increased risk of dementia overall, but if you look at the subgroup analysis, they suggest that there might be an increased risk to vascular dementia. And that could correlate with this kind of white matters, that abnormalities that we saw. So not everybody with neurological problem will respond to the diet, so why don't they all respond? This is a letter from a GP to me. You can see that our GPs are extremely well trained in Sheffield. Not only he diagnosed the ataxia, but said, could it be gluten ataxia? Which also was quite interesting. Don't know what happened. I've got it here. Yeah, okay. And then, of course, my response was your provisional diagnosis is spot on, but I also said my suspicion is that lack of adherence to the diet, which, of course, is often the case in these cases. And here is a blood result from this patient. You can see gladins are positive, transglutaminase is positive, and this is despite the fact that the patient said that they were on a strict gluten-free diet. So by far the commonest explanation is poor adherence to a gluten-free diet. If the diet is very good and the patient is getting worse, I think you have to review the diagnosis. Sometimes you have an alternative, a degenerative cause for ataxia. Or the patient, if they are very disabled by the severity of the ataxia, you might not be able to demonstrate improvement as such. But that's where spectroscopy can be very helpful. If you show some improvement, it encourages the patient to continue with the diet. And finally, as I said before, you need to consider refractory celiac disease. So the next question is, are we dealing with two different cohorts of patients? Those who present with gastro symptoms, the classic CD, and those who present with neurological symptoms? Or is there overlap? So to answer this question, we did a 3-year prospective study funded by Celiac UK, where we examined neurologically and with imaging 100 newly diagnosed patients with celiac disease coming to the gastro clinics. And the mean age at the diagnosis of celiac disease was 43.8 years. And patients were asked about balance problems, sensory symptoms, frequent headaches, and there you are, 42% complain of frequent intractable headaches, 24% of poor balance, and 12% of sensory symptoms. In total, 61% had neurological symptoms. And on examination, 42% had neurological dysfunction on clinical examination, mainly gait instability, some had nystagmus, some had distal sensory loss suggestive of a neuropathy. And when you looked at the scans, 44% had abnormal spectroscopy of the cerebellum versus 3% in age-matched healthy controls. And the white matter lesions we talked about were seen in 19% versus 3% in the healthy population. So the conclusion is that patients with classic presentation of celiac disease frequently have neurological symptoms and signs that remain unreported by patients and not detected by doctors, primarily because no link between is considered. So if you're going to see your gastroenterologist, you're not going to start talking about your headaches, for example. Next question is, are there any clinical and serological differences between the patients with celiac disease presenting with neurological manifestations versus those who present with classic celiac disease? Well, the first thing to point out is the age at diagnosis. So clearly, those patients who present with neurological problem are diagnosed about a decade later. And the patients with celiac disease presenting with ataxia have a more severe neurological dysfunction than those with gastro presentation. And when you look at their brain collectively, so this is a methodology called voxel-based morphometry that allows you to compare the brain of a group of patients with the same disease to a healthy controls. On the top line here, these are newly diagnosed patients with gastroceliac disease. And there's already this yellow area suggests that there is loss of gray matter in the upper part of the cerebellum. But if you compare it with the ones who present to us with ataxia, you see that there's much more loss of gray matter. So they're much more severely affected. In terms of the serological observations, the CD gastro group, by definition, will have a very high positivity for TG2, and so would the neuro group who have enteropathy. But if you look at the TG6, which is this antibody that we think is associated with the neurological manifestations, both groups, remember, have enteropathy. The prevalence of TG6 in the CT neuro group is much higher than in the non-neurologic group. So are there any differences between patients presenting with gluten sensitivity and neurological dysfunction with and without enteropathy? In other words, this group of patients that we'll hear a bit more from Umberto Volta later, the non-celiac gluten sensitivity. So we divided the patients on our database into those who have enteropathy and those who don't. And then we wanted to see if there were any differences between those groups. And the simple answer is that there aren't any. So this is a type of manifestation in the celiac group and the non-celiac group. And they are more or less identical. There are minor variations, but not significant. And then, is it that the neurological manifestation is more severe if you have enteropathy or if you don't have? Well, the answer is no. I, as a neurologist, if I see a patient, I cannot tell whether they are going to have enteropathy or not on clinical grounds, only with the serology and the biopsy. In terms of the serological test between these groups, remember that we said already TG2 is high prevalent in those with enteropathy. Interestingly, about a third had low levels of TG2 for the non-celiac gluten sensitivity neuro group. But when you look at TG6, again, you see that the TG6 is much higher represented in these groups than in the gastro group. So the conclusion is that there are no clinical neurological differences between patients with enteropathy and those with non-celiac gluten sensitivity in terms of the type and severity of neurological dysfunction. And both groups are equally responsive to a gluten-free diet. A bit about transglutaminases. So the three important ones is TG2, which is the autoantigen in celiac disease. TG3 has been shown to be the autoantigen in dermatitis herpetiformis. And TG6 is the one that we found to be linked to the neurological manifestations. The three transglutaminases have a 65% homology. They share the same genetic background, and they are all capable of deamidating gluten to form these toxic peptides. and the titer goes down when the patient goes on a gluten-free diet. The fact that TG6 is important for cerebellar functioning has also come from this paper that mutations on the gene that produces TG6 have been shown to cause spinocerebellar ataxia, and it's called SCAR35. So TG6 antibodies are more prevalent in celiac disease patients presenting with neurological dysfunction. TG3 and TG6 are primarily expressed in the locality of the tissue involved, skin or brain respectively. TG2 is more widely expressed, including the vessel wall, and transglutaminase antibodies react with neural tissue and can induce ataxia in mice. This is a mice model. Are extraintestinal manifestations a late phenomenon? Well, you heard earlier that there is a decrease in the prevalence of dermatitis herpetiformis in Finland since the introduction of screening programs. I told you that the average diagnosis of celiac disease in neurology patients is 53 versus 44 in gastro patients. Recent evidence from pediatric cases, this is a paper that is currently being reviewed, of celiac disease suggests that the prevalence of TG6 antibody in the pediatric cohort increases with longer exposure to gluten. And then some more general conclusions. Patients with celiac disease who present with typical gastro symptoms are more likely to be diagnosed and treated early, thus reducing the risk of development of neurological dysfunction. So if you're lucky enough to have GI symptoms, you are more likely to be diagnosed early and therefore more likely to stick to a diet and prevent the development of neurological problems. Poor adherence to the gluten-free diet is the commonest cause of development of neurological dysfunction, and I think this is a major problem, particularly for the neurology cases. Patients with non-celiac gluten sensitivity and neurological dysfunction benefit equally from a strict gluten-free diet. And I think clinicians need to be aware what serological testing is needed to diagnose such cases. And also there's an urgent need to screen and diagnose patients with neurological presentation in order to prevent permanent neurological deficit. And I'm really pleased that the NICE guidelines from last year included ataxia and neuropathy as things that you need to screen for celiac disease. So the last very few minutes, I just wanted to present something very new to you, which is a study we just completed on cognition and gluten sensitivity funded by Celiac UK. This is taken from a report of one of our patients with gluten ataxia who went and had neuropsychological assessment. So what you need to be aware is that the cerebellum is not just a balance organ, it's involved in cognition as well, and we're learning more and more about that. So it can cause impaired executive function, reduce processing speed, impaired spatial cognition, and language deficits. And in this particular case, the report concluded that executive dysfunction and difficulties with expressive language impact on this lady's ability to manage complex relationships, a lot of problems within the family, as well as impacting on decision-making ability regarding the gluten-free diet, because she's not on a gluten-free diet. She just couldn't understand why she should go on a gluten-free diet. So this pilot study was completed at the end of last year. So we recruited 19 patients with newly diagnosed celiac disease and then 40 patients with established celiac disease for over 5 years, as well as 20 healthy controls. So the established diagnosis group was then subdivided to those with strict gluten-free diet with negative serology and those with non-strict diet and positive serology. Some of them said that they were not on the diet. All the patients underwent this 2-hour session of cognitive assessment, and the assessments we included standardized tests selected based on our experience of assessing patients with celiac disease and cognitive complaints over a number of years. So the groups were matched for years of education, estimated premorbid IQ, and anxiety and depression scores. The newly diagnosed group and the control group were matched for age, but they were younger than the two established diagnosis groups, as you might expect, because those were the ones who were already diagnosed with celiac for at least 5 years. So where relevant age was used as a covariate. So we found significant group effects in certain tests like block design, trail making, Part B, immediate and delayed visual recall, all of which are kind of connected to cerebellar functioning. And the post-hoc analysis showed that there were, firstly, no significant differences between the newly diagnosed patients with celiac disease and the healthy control group, with the exception of immediate visual recall, that was worse in the celiac group. But as you then move on to the patients who had celiac disease, there were additional differences between the celiac disease adherent group to the control group in block design and metric reasoning. And then as you looked at the group of patients who were not on a strict gluten-free diet, these differences became much more prevalent and much more significant. So what does that tell us? It's a pilot study, but it does indicate that there appears to be a cognitive impact of celiac disease. The extent of this depends on time since diagnosis and gluten-free status. There is a trend evidence supporting the protective value of maintaining a gluten-free diet. And of course, there's further investigation that we should be doing in this area. But remember that the patients we included were all patients that were not under my care. So we didn't include those patients that you knew for a fact that they would have neurological deficits. So it's slightly biased for a better rather than for the worse. So that's all I had to say. Just a big thank you to a group of friends and colleagues who work in this field, and also the financial support by Celia UK, Ataxia UK, and Brett. Thank you very much.
Thank you very much, Marius. Probably got time for one quick question if anyone has any burning questions. Umberto.
Thank you, Umberto Walter. Thank you, Mario, for your excellent presentation. Some years ago, we described the high prevalence of antibodies to neurons in patients with celiac disease with neurological manifestations. About 60% versus 5% in celiac disease with gastrointestinal presentation. Have you any experience of these markers? I mean, cerebellar antibodies, ganglioside antibodies, and others.
Sure. What we know is that the transglutaminase antibodies do react with Purkinje cells. So when you do a histochemistry or say a rat cerebellum and you use serum from a patient with gluten ataxia, you will show quite intense staining. So I think that the staining you see in those assays we call neuronal, but in fact are probably transglutaminases that react with that.